Hey, here we are at Critical Care Pharmacology. I have Erin Lingenfelter, and she doesn't even know how to pronounce her own last name because I tried to get her to tell me.
It's true.
So she's an amazing pharmacist. She teaches pharmacy for, well, this is how I met her, for AirMed. She works in the emergency department at the University of Utah as a pharmacist, but then her expertise goes a lot further than that. And I'm going to let her introduce herself and tell you a little more about herself.
Sure. Hi, guys. A little bit about me. I'm actually practicing at the University of Utah Emergency Medicine. It's actually the first emergency medicine practice for pharmacists in the state of Utah. We've been doing it for about 12 years now.
Really? It's the first?
The first one. So we were on the ground running. One of my coworkers and I, had to kind of make up our own job description and made sure that we were as clinically relevant and needed as possible. And I think that's why our job has become necessary in our department. So to start off, we're just going to talk about what pharmacology actually is. It's obviously a vast amount of data and information, but really boils down to just the study of the preparation, the properties of drugs, their uses, their actions, and how they can potentially be used to actually diagnose different disease states. So in terms of when I've been teaching transport experts in the past, and we found that they need more than a basic understanding of these drugs. So when I teach some of our nurses and paramedics for our flight team, I'm not going to just give them a slide and say, here's information, retain it. I'm actually discussing back and forth with them about how we're actually use these drugs, when are they appropriate, when they're not. Give them some clinical pearls so that when they are on their own, they can grasp that piece of information and try to apply it as rapidly as possible. So the biggest things I really want to bring up across when we talk about pharmacology is no drug is benign. There's no safe drug, no fluid, no Tylenol.
Wait. Normal saline is not benign?
It is not benign. You can over resuscitate someone, cause pulmonary flash edema. You can cause metabolic acidosis by hyperchloremia. So yeah, normal saline, not benign. The other things that we want to talk about is how to make choices based on the knowledge you have in evidence-based medicine. It's not just because Dr. Google told you so. It's not because I told you so. It's actually because you are becoming the expert on the drugs you use during transport. You should really innately know your own policies, regulations, resources, protocols, and your scope of practice within your own team, your own outfit, and for the state and federal laws. But most importantly, you should know what's ethically appropriate. There are some things that we just shouldn't do in flight, like enrolling someone in a study that they didn't consent to would be an example of an unethical use of a medication. Other things that I want you to be aware of is when you are doing these transports, you are actually practicing at the top of your license. It is your professional responsibility to be abreast of up-to-date information and evaluating the strength of that data presented to you. So it's not just a quick look up and I have an answer. It's actually, do I understand this information? Can I apply it appropriately?
So what you're saying is your department, the department you work for, has the responsibility to let you know all the latest and greatest updates.
I actually disagree with that.
No, I do too. I was just throwing it out there.
It's actually your own professional responsibility. It's a personal, almost moral thing that I have ingrained in me, that if I'm going to take care of people's lives, I need to be as up to date, as applicable, as reasonable as possible. Now, are there times in hectic, chaotic situations where you have to make the safest decision possible, and it may be not the sexiest and most sophisticated decision that there's out there in the medical field? Yeah, you're going to have to make a safe, efficacious decision, but it may not be sexy.
So I understand the general concept of beta blockers, and we carry certain beta blockers, and I've used certain beta blockers in the ICU and in the ER. But for example, the other day, and I've heard about esmolol and I've read about esmolol, but I've never actually given esmolol. And this doctor wanted to start esmolol before we flew this patient. It was a AAA. And I pulled up my up-to-date and I did a quick review, but I did not have like this deep knowledge of that particular drug, but I knew beta blockers and I knew this one, was a fairly strong one. And so I used it.
Well, I think one of the things you really point out just there is you actually looked up information and then just go with it. So you did that next step to try to figure out as much information as you could in a bad situation. I think when people look things up, they're the smartest person in the room. So some of the tools that you can use is, if you're based out of a specific institution, you can use their hospital formulary or the list of drugs that they allow at their institution. Knowing standard concentrations of drugs if you're going to have to make drips on the run is super important, because you may be transporting from hospital A to hospital B, and they may have completely different standard of concentrations. It may be completely different than what you do in flight as a normal practice. So it's knowing and paying attention to those different concentrations. We'll talk about errors in transport in a little bit. So another way to keep up with your medication information is continuing education. I know a lot of people who just go to CE, or you guys call it CME actually, I think, and just sit there and maybe play on their phones or doodle the whole time. Actually go to CE that's applicable to you, so you actually are interested in it. I know a lot of us are just trying to slam our CME so we can keep our licenses, but if you actually pick out things that mean something to you, you're much more likely to pay attention and retain it. And worst comes to worst, let's say you can't travel to a convention or to a conference. A lot of these conferences after the fact will provide cheaper version, cheaper than registration, the actual slides and audio or visual of these things, and you can download those.
You just go to their site that hosted the conference.
Yeah, some of them actually do that. So you may not be able to be there in person and have that active learning and interaction with and networking, but you may still have the visual learning opportunity.
That's great to know. Thank you.
So here comes the big thing, the internet. Now I'm 35, so I span the new age world of having information instantly available to me, and the girl who had to go and get articles off of Fish in the library. So I'm a little hesitant about the internet, providing medical information, mostly because there's a lot of people out there who don't know what they're talking about.
So answer me this then, because, and maybe it's different for pharmacology, but I use Wikipedia. Like, say I get a patient, when I was in the ICU, I'd get a patient who just had a Whipple. Now, I don't need to know everything there is to know about a Whipple, but I at least need to know what it is in the basics. So I'd go to Wikipedia and I'd get a pretty concise definition of what it is, and then I knew what I was dealing with. Using Wikipedia for that medical knowledge, do you feel like it's not
So for medications, it's tricky, because when you crowdsource information, it can go one of two directions. It can go incredibly basic so that everyone understands, or it can go way beyond applicable knowledge, and then it's unintelligible and you can't really apply it. So there are web pages out there that are called free open access medical information. It's short for FOAM. I think it was developed somewhere over in the British Empire. No,
we're the empire now.
Great Britain, excuse me, where they a lot of medical professionals over a pint of Guinness, looking at their foam, said we should name something medical after this. Google me, see if I'm right about that or not. So anyhow, foam is actually peer-reviewed information. So you're going to look to, if you write an article, let's say you're going to write an article about the application of metoprolol in acute MI or a myocardial infarction. You may write an article and then you may submit it to several experts or peers of your own practice to see if that information is correct. You would cite it with evidence-based medicine, literature, articles, primary literature, such as studying if metoprolol is good or harmful in acute MI. And there's always been kind of that question, should we be doing that or not? So you could go and read some of these articles. So in terms of the emergency medicine and critical care world, we're the lucky group, because we're the ones that are a little more ballsy and a little more social. And we have a ton of this information out there. We're the forefront of foam. Using the internet for that reason, I'm very supportive of. There are also experts out there who have their own blogs and podcasts, and I could throw some names out there, but I don't know if we're going to really give them props for all the work they do over this forum. But there's some really great people out there doing this information. Here's the downside of using foam in blogs and podcasts for education. People, and by people I mean learners, really should take the time to go to that base science, those primary literature articles, going back to the mechanisms, pathophysiology, the receptor level of cells to understand medications and medical disease states. There's just not enough time in podcasts, blogs, and foam to actually develop and present that information accurately. So I still tell all my learners, they may look something up and they're like, hey, I just found something on EM crit. And I go, great, go back and read the articles from that EM crit that you just listened to, and then we'll have the conversation about it.
Actually, I found it right here. The term foam was coined in June 2012 in a pub in Dublin over a pint of Guinness. Good to know.
See random facts of medical knowledge by Erin. Another option is a lot of hospitals, institutions, or outfits will have subscriptions to medication-specific information. So examples of that would be Micromedics, Lexicomp, or Diomed. You may see them in book form. You might see them as a link that you can click into on your intranet. Those are very solid sources of information. There are subscriptions like Up to Date. Once again, you're trusting experts to present information to you. Just remember to go back and do your own learning if you need an extra level of learning. Apps and calculators that you can put on your phones. So I have one on my phone for pediatrics. Where I work, we don't have a large population of pediatric patients that come through.
Because you're right next door to...
I'm right next to a children's hospital.
To primaries.
Yeah. So when a kid comes in my ED, the first thing I do is pull out like my emergency dosing. Because if something went down, I'm not sure if I could confidently recite what I need to do quickly. So I have a book version of pediatric. I have apps for pediatric dosing, and then we've actually created a calculator at our university for pediatric dosing. So
sounds like something you would do. Create a calculator.
Actually, one of my residents made it. I won't take credit for it, but yeah, it's super applicable. The other things you can have for yourself or your agency or your outfit is to maybe have for lack of a better word, maybe a small version of a spiral-bound book for your protocols, your drugs, your monographs for those drugs to kind of remember your dosing when you're in a bad situation. It's a good idea if you can laminate those, because when we're out in the field, those things get messed up pretty quickly.
And you can make those. I've made these before. You get your policies, shrink them down, other things you think you may need, and go to Kinko's, get it laminated. They'll spiral bind it for you.
I've got label makers. I've got my own laminator.
So you do it yourself. Or go to Erin's house.
Pharmacy nerd, dude. So there's also like published cheat sheets. Maybe your medical director for your agency will put something together for you. So here's a plug for pharmacists. Maybe consider enrolling a local critical care pharmacist or emergency medicine pharmacist. Most of the time we'll review this stuff for free. We'll point out things that maybe aren't exactly kosher in the field, or maybe you haven't been using to its full extent. And we can work along with your medical director to make sure that we're fitting your guys' protocols. And
don't hesitate to ask, whether you're doing, your regular ground transport or critical care transport, you're dropping these patients off at the bigger facilities with the more resources. There's always a pharmacist around, and they would love to come talk to you and explain to you this drug or that drug or whatever. They're a very good resource to use.
Another part of having the art of experience is knowing what's more important to happen, right this moment. So is blood administration more important right now, or giving that antibiotic for the open compound fracture? So that's why developing experience will help you in a lot of these decision making when you talk about which medication to select. The definition of pharmacokinetics. So this is one of my favorite things about drugs. It's a study of metabolism and the action of the medications within the body. So how is the drug absorbed? What percentage of it is absorbed? Onset of action, duration of the action, distribution in the body, and the mechanism for excretion. So we'll talk about a lot of those things individually. Absorption is a really important concept. It's the thought process that depending on how you administer the medication is what the percentage of the drug is absorbed. So at baseline, 100% of any drug given intravenously is absorbed because it's already in your bloodstream. But when you start thinking about giving things either intranasally or orally or rectally, you start losing some of those potencies, not potency. You start losing some of the percentage of what is actually absorbed to the body. You might lose some of it in the meantime. So the ranges of oral absorption really could be 0 or it could be 100%. Some medications are maybe safe to be administered orally, but dangerous at that same dose intravenously. So the example I like to use is metoprolol. It's a beta blocker. You can get 50 milligrams of it orally completely safely in majority of patients. But if you get 50 milligrams intravenously, you're probably going to off that patient. There's lots of different formulations and ways to administer medications. So there are sublingual and oral versions. Intravenous, an example of why intravenous is different than oral is magnesium sulfate. You have 100% bioavailability in the IV version, but for oral, we absorb very little through our gut. Bioavailability is essentially the percentage of the drug that is absorbed.
What about when you're talking about like drugs that bind to proteins, like ions that are disassociated or whatever, like bioavailability, if it's there but it's not usable in the bloodstream, is that bioavailable?
That's a really good question. I think it's two different concepts. So essentially the question was, is whether or not a drug is available on the action of the receptor part of bioavailability. It's more about the protein binding, not that drug not being available. So an example of that is ceftriaxone, common antibiotic we use for pneumonia or urosepsis. It's 95% protein bound. So in patients that are older or who have liver failure, they have low albumin in their body, there's more free drug available. That means the body can eliminate it faster. So that means the drug is gone from the possibility of even trying to exert its effect. So it's about elimination and metabolism more than about bioavailability. There's, of course, intramuscular administration. A lot of drugs you can give IV, you may be able to give intramuscularly. Hydromorphone is a great example. You'll still get the properties of pain control, maybe sedation, respiratory depression, but you're not hitting the peaks of concentrations in the blood that you would if you just gave it intravenously. Some of the more interesting things out there, we talked about inhalation or nasal administration. So we use albuterol nebulizers versus an inhaler because someone who's in distress can't use an inhaler correctly. Intranasal administration is great. It's actually a research love of mine. I've done some research in intranasal administration meds. So the most famous one right now is naloxone.
So do you understand boogers pretty well then? I mean, you must.
I don't have kids, so I've decided not to make that a part of my expertise.
Well, what if they're full of boogers? Is it going to absorb? I don't know. Is it?
You blow their nose. I have techniques. But yeah, you would have to blow their nose if possible. Not everyone who is unconscious from opioid use can do that for you, though. No one really loves going there, but rectal suppositories and administration is actually a centuries-old route of administration. And it's actually really effective. It can go straight into the bloodstream from absorption of the capillaries in the colon, and it actually is longer acting than some IV meds. Not that we were doing this en route, but there's lots of different other forms of administration: ocular, intraarterial, otic, which is in the ear, epidural. So. The next pharmacokinetic concept is distribution. It's actually not a really easy concept, so I try to break it down into the following thought process. Depending on how the medication is administered may depend on where the drug goes to first. Distribution is not just your bloodstream. It could be extracellular fluid. It can go in and out of the fat content of your body. It could also be part of your cerebrospinal fluid, synovial fluid, or even if you're pregnant, it could go and have a larger volume of distribution if you're pregnant in terms of not just hemodilution of your blood, but also into the across the placenta to the fetus. So the reasons that volume of distribution is important is it actually determines where the drug can get to so it can enact its action. So things that would affect distribution would be how big the molecule size of the drug is. Vancomycin, an antibiotic for MRSA, is a huge molecule. It can't get to everywhere in the body to treat it. Things about positive and negative ions on drugs. Protein binding affinity, like we talked about with ceftriaxone, volume of distribution issue. We also talk about lipophilicity. So how much does the drug like fat? So examples of these is the placenta and the blood-brain barrier. You have to have very lipophilic drugs to cross it. An example of that would be diazepam. So patients in alcohol withdrawal, we may use diazepam or Valium for patients across the blood-brain barrier to help treat alcohol withdrawal.
So it's lipophilic.
It likes fat.
That's what crosses the blood-brain barrier?
You have to have that property in order for that blood-brain barrier to support its transport. So if it's like a hydro, like a water molecule, it won't transport because it's a lipid layer. So you actually have to have a lipophilic drug to cross.
I imagine propofol's very lipophilic.
It's very lipophilic, which is why people go unconscious when you use propofol. There are active transporters that can take drugs across blood-brain barriers and placenta, but that's another day.
Okay.
So another concept would be penetration. There's an antibiotic called daptomycin. We use it for methicillin-resistant Staph aureus. We would actually use that empirically to treat, we would not use it empirically to treat pneumonia because the surfactant in your lung actually deactivates daptomycin. So that would be an volume and distribution it cannot get into because it's inactivated. We talked about ceftriaxone already, and then there's a concept of first pass effect. First pass effect is actually specific to orally administered medications, and it's primarily done at the site of the liver. It causes the biotransformation of the drug, either metabolizes it down to inactive or active metabolites, or it makes it so you can excrete it from the body. So I use the word metabolism or metabolites. There are 4 main concepts about how metabolism happens in the body. The first one is you have an active drug and the liver makes it an inactive metabolite. Example of this would be phenytoin. Another type of metabolism is active drug to active metabolite. Most of the time, the active metabolite will be weaker. A good example would be morphine to the active metabolite morphine 6-glucuronide. But sometimes it's stronger. Codeine actually is metabolized to morphine. That's why there's pain relief from codeine.
Oh, that's why it's a controlled. I mean,
Substance.
codeine's controlled. It's not morphine, but it turns into morphine.
Exactly.
Wow.
And very clever basement chemists out there in the world can make high potency opioids from it. Another metabolism is activity is to make an active substance into a potentially toxic substance or drug. So everyone should have heard how acetaminophen is one of our number 1 causes of liver failure and death in terms of overdoses in our country. So the liver actually hydroxylizes acetaminophen to a compound called NAPQI, which is a free radical scavenger and actually causes damage to the liver. And then finally, they may take an inactive substance and create it into an active drug. So we call these prodrugs. An example of this would be fosphenytoin. The liver actually converts that to phenytoin to be an active drug. The liver is actually able to accomplish this through a system called cytochrome P450. There are many, many, many of these proteins that I still have PTSD from pharmacy school trying to memorize these. These proteins are actually enzymes that cause enzymatic reactions to metabolize drugs.
So cytochrome P450 is a group of enzymes.
It's a group of enzymes.
Okay.
Sometimes people just say P450, and try to get away with it. So
I'm sure you call them out on that, knowing you.
I'm not really good at them, so maybe not.
Oh, okay.
So lots of things can affect the P450 system, including drugs, foods are actually can affect these a lot, or chemical exposures. What happens is they can actually induce the enzyme to work harder or inhibit it to slow down. So examples of some things that could affect it are nicotine. There's a drug class of antipsychotics called MAOIs, and even grapefruit juice. So if you ever have like your family member or yourself on, let's say, atorvastatin or Lipitor, and it says on the side of your pill vial, do not drink with grapefruit juice, it actually is because it makes the drug not be able to go through the P450 system correctly. And another important concept in pharmacokinetics is elimination. There are 2, and depending on who you talk with, maybe more concepts of what kind of elimination there are. So there's zero order kinetics. The idea here is that a fixed amount of drug is eliminated over a period of time, regardless of how much drug is present. Examples of those would be aspirin, alcohol, or phenytoin. But then most drugs are actually eliminated in what we would call first-order kinetics. This is the idea that the drug is eliminated over a period of time proportional to the plasma concentration. It has to do with the half-lives of the drug and how long it takes to eliminate it. The biggest thing about first-order kinetics is you need to remember is that steady state occurs when the rate of administration equals the rate of elimination. Of course, we had to make this complicated and tell you about all the things that make biotransformation elimination difficult.
I don't think you can talk about pharmacy without it being complicated.
Yeah.
Even your basic aspirin.
That's true. Lots of things about patients' specific body habitus or genetics or even their ability to eliminate drugs are very specific from patient to patient. So how well their kidneys or liver perfusing? Maybe they're in shock, and so some of these biotransformations or eliminations can't happen. What's their baseline functional level of their liver and kidneys? Do they have an increased metabolism rate for some reason? For example, burn patients. Burn patients are extremely hypermetabolic and can clear drugs way faster than a normal person who does not have a burn. What's the extent and rate of absorption? There's some patients that have short gut syndrome where they have a lot of their intestine taken out for various reasons, and they may not be able to absorb the drug at the level it's supposed to.
I remember we had a patient in the ICU in liver failure. In fact, he had a transplant, and we had to be so careful with the pain meds that we gave him because they would last for days. Like you put them out and then he wouldn't come to forever.
Right. And that's incredibly common. And it's sometimes one of those lessons you learn too late. I've had conversations with doctors who don't realize that a paralytic is still on board of a patient because they're liver failure. And they're talking about withdrawal of care. I'm like, stop. The opposite side of pharmacokinetics is actually pharmacodynamics. And this comes down to what's the relationship between the drug concentration at the site of action of that drug and the resulting effect. Really what I'm talking about is mechanism of action. So you don't have to use all those other words. Pharmacodynamics is mechanism of action. In terms of the theories of the mechanism of action, every drug's going to be different. I don't think that's a surprise to anybody. But the thought process is the drug has to be present at the cell receptor site to promote or inhibit a specific cell activity. That cell's physical activities and properties may alter because the drug is present. Also, if you directly combine these drugs with other body chemicals to alter or limit the chemical's effect. So maybe an example is trying to do elimination of an aspirin overdose by using sodium bicarbonate. So you're not really acting on a certain level, but you're trying to buffer the region so it can eliminate it easier. And then finally, you might be altering a metabolic pathway to achieve a desired result. So your normal Krebs cycle, you may be throwing something in there or blocking something from the next step. This is where things get actually active. It's the effects on the receptor site. A receptor, for lack of a better definition, is the target of the drug action. So there are two different things that can happen on a receptor site. There's something called an antagonist or agonism. This actually activates or stimulates a receptor to produce a normal physiological response. So that drug may mimic the action of an endogenous substance already available in your body, or maybe it's depleted for a reason. So when we talk about people in shock, a lot of times they're exogenous chemicals they create in their body already. Chemicals like norepinephrine or dopamine may be depleted because you're in shock. We may give it more so it can enact an activity. The opposite of an agonist or agonism is antagonism. So being in the concept of opposite, it could block the receptor site from being stimulated. Or drug B could decrease the effects of drug A. An example of that would be opioids and naloxone. You have opioid on a mu receptor causing the pain relief or the side effects of respiratory depression. You can give naloxone to compete with that, and you would have the reversal of those effects. The other option, another way this drug works is it just blocks the action of an endogenous substance. So there's some concepts in terms of competitive antagonists. So like, how we talked about kicking the drug off, like the affinity. Competitive antagonists have a higher affinity. And then non-competitive antagonists, they may alter the configuration of the receptor so that the receptor just doesn't even recognize the drug or an endogenous substance anymore. So this all depends on binding strength, affinity, and concentration available at the site. To bring this all home, you have an agonist alone could create this large action potential. You could have an agonist and an antagonist together that may compete for an action and maybe make a lesser response. Or you could just have an antagonist alone and it may present little to no response. Onset of action is really important during transport because you want to know what the time it would take for a drug to start working. A lot of people get anxious and think, okay, I gave some drug, it didn't work, I need to give more. So knowing a baseline knowledge of the onset of action of a drug is incredibly important so you don't stack medications on a patient.
I think this is huge when you're talking analgesics, narcotics, benzodiazepines. Give them a minute.
It'll catch up on you and you will be in a bad position when it does. The pharmacy way of describing this is the time it actually takes for a minimal concentration of drug to activate a result. The duration is also incredibly important. You should know how long your drugs should last, so that way you can be prepped for when maybe the next dose is due, or maybe you need to be able to examine a patient, so knowing how long a benzodiazepine or a paralytic will last, so you know when you can get an examination again. And then finally, there's the termination of action. How long it takes for the concentration to fall below minimum concentration due to either metabolism or elimination from the body. There's a concept called the therapeutic index, or some people call it the therapeutic window. This is the medication's margin of safety. Like we talked about before, no drug is benign. So it's either if you get to the point where it's efficacious, and there's a window of that efficaciousness, if that's a word, I guess. And then above that, it may be toxic results. There may be some discussion about effective dose range. So sometimes you would talk about whether or not there's a 50% of population be effective at that concentration, and the other 50% of people would not be able to concentrate at that concentration. Therapeutic index, or also known to some people as therapeutic windows, is the medication's margin of safety. You get to a certain concentration where the drug is actually able to do its job and be active. And then there's a window of how high that concentration go before you get to a toxic level. So there's two concepts of that. One, there's the effective dose, meaning that it's effective in 50% of the population at that concentration. And then there's lethal dose. It doesn't really mean you're going to die, but it's the toxic dose for 50% of the patients. Everyone talks about half-lives. And they talk about it in a way that drives me nuts because they actually aren't applying it correctly. A half-life is actually the time it takes for 50% of the concentration to be eliminated. And then people think, 50% one time around and 50% around the next time around, the drug's gone. That's not true. It's 50% of the drug is gone the first half-life, and then it'd be 50% of what's left again. So 25% will be gone the second half-life.
So theoretically, it's never gone.
Theoretically, okay, that was deep. That was very deep thought. I appreciate that. Theoretically, it takes 4 to 5 for elimination of a drug. 4 or 5 half-lives, excuse me. And that's going to vary from person to person based on their metabolism skills, their elimination rates, and it could even just be their gender, their weight, who knows? It could be any amount of cofactors there. One of the things that I pride myself on as a practitioner is really taking individual patient-specific characteristics into effect. If you're not paying attention to some of the special needs of each individual patient, you're going to treat every patient as a standard dose. And standard dose does not apply to patients. So the easiest one to think about is age. There's kids, there's regular, healthy adults, and there's elderly. Pediatrics are notorious for metabolizing drugs way faster than adults do and excreting them too. But then you have the elderly, they have decreased renal function potentially, they have decreased muscle mass, And they have changes of their water versus fat content, so that affects their volume and distribution. One of the reasons that it's very hard to predict these things is almost all drug studies are performed on healthy young males.
Usually in war, right?
That's how it actually started. It's like whoever you had a controlled population in, soldiers are a controlled population.
So isn't it? It's the 70-kilogram white male patient.
Yes, it's the white male patient, 70 kilos. Exactly. There's a lot of 70-kilo white males out there that have things running around their body that they don't even know about. Hopefully the government's not listening right now.
They always are.
Weight-based dosing is really important. You have lots of different weights you have to choose from, though, which is unfortunate. Once again, it goes back to how drugs were studied. You have ideal body weight, you have an adjusted body weight for the obese population, and then you have actual body weight. So a lot of drugs in transport don't always get affected by this. It's some of the more hospital-based medications, but you could get stung by some of these things. There are dosing limits based on weight and obesity, like max doses you should be giving to people. But there's also the concept of if you're not using the patient's actual weight, you're not filling that volume and distribution. So there is debate within the medical and pharmacy world about those things still.
Whether you base it on actual weight or ideal body weight.
Yeah, there's still debate about those things. So an example would be acyclovir. We use it intravenously for patients with viral meningitis. There's some people who say you should be using actual body weight because you need to fill the volume and distribution, get the concentration to the site. And there's other, it's how it was studied originally was ideal body weight, because too much drug, you worry about causing like interstitial nephritis from crystallization. So there's a lot of debate even within ourselves. I provided here the ideal body weight calculation in case you ever need it. I highly doubt you're going to need to use this, but in case someone pushes it, you have it available to you.
Well, and we actually do use ideal body weight in ventilator management, so...
Oh, see? I don't do ventilators, so that's a good thing to know. There it is.
There it is. Drop the mic, walk out of the room.
There's different body masses differences between the sexes of male and female, so that can be a contributing factor for drug response. You have to think about the environment, the site of absorption of medications, and whether or not the drugs have a response or not. Do they have co-ingestants of drugs or substances that might bind the other drug? Did they drink alcohol, or did they take a drug that could cause gastroparesis or peristalsis? Maybe they won't have enough time at the site of absorption to be absorbed. And then there's things like food. Food ruins everything in drugs. Pharmacists either want you to take food with it or not take food with it, or don't use anything with calcium in it. So the long story short, in terms of calcium and tube feedings, it actually can bind medication. So it's not even available to be absorbed to make it into the bloodstream. And then there's a patient's overall body condition. Is this an overall healthy patient, or do they have malabsorption problems? Do they, where is their feeding tube located at? Sometimes when you have a feeding tube too low, you can't actually absorb or create the acid to have the drug break down for absorption. If a patient's in shock, cardiogenic or septic shock, anything that could decrease their blood pressure, blood actually gets shunted away from the stomach to try to make things that are more important keep running, like your brain and your kidneys. And so you may not absorb drugs orally. So when we have drugs that are 100% bioavailable, so 100% at IV form and 100% at PO form, like levofloxacin, an antibiotic, if someone's in shock or they're in septic shock, I'm not going to use an oral antibiotic in them because they may not absorb it. And then another problem could be if the patient's hypothermic or they're in hypermetabolic state. And then comes the genetic factors. There are different ways of kind of explaining this, but at the end of the day, there's a concept called genomics in medications in particular, and it pretty much says that different populations of ethnicities may have higher or lower concentrations of some of these P450 system cytochromes that we talked about earlier. So we call those polymorphisms. It may be the lack or overexpressed amount of enzymes for a particular drug. So a not common one, but a good example one of how drugs can really hurt someone is the glucose 6-phosphate dehydrogenase deficiency. It's a recessive gene deficiency that patients may not know about unless it's in their family or they've had a bad experience with some of these drugs. So it would be a bad idea to give this patient population sulfonamides or nitrofurantoin. So once again, drugs are not benign.
Going through everything you just went through about pharmacokinetics, pharmacodynamics, and all the factors that affect it, it's a wonder that we can depend on any drug to work ever, because we don't know anything that's going on in this patient's body other than the things we can guess based on their outward signs and symptoms.
So when I'm teaching my learners, the things I always try to hammer home, and I've said it several times today, is drugs are not benign, drugs are not predictable, and there's no standardization of dose. Why do genomics and patients' response with their enzyme levels matter? Well, they're drugs with narrow therapeutic windows, such that are very important for various disease states, that may not work well or may have too much built up in the body and cause toxicities. So drugs with narrow therapeutic windows, and there's lots of them, but ones I want to that could talk about easily about were clopidogrel, warfarin, carbamazepine, a lot of the anti-neoplastics for cancer treatment, and some of the more novel hepatitis C treatments. So there's lots of these out there. I don't think any of us will be major experts on them, but just kind of know there may be variability in response because of this. Pregnancy can affect the drug response. We don't always have information in terms of how it'll cross the placenta or into breast milk with some of the newer medications. A lot of times it's just research of patients who've been exposed. But the biggest thing we know about with pregnancy is hemodilution happens. You actually have a larger blood volume during pregnancy, and so that affects your volume distribution. So it could dilute out your drug. And then, of course, there's always psychological factors for medical care. I think the most famous one is placebo effect.
MASH, that MASH episode.
Oh, tell me about it.
Well, they were out of morphine, and they have you've seen MASH.
Yes, I have.
So they're out of morphine, and that's it. And they've got all these soldiers who've been wounded, and so they tell them, we're giving you morphine, and it worked.
Well, believe it or not, doctors up until like the early 2000s could prescribe something called Ulbacap. And it's placebo spelled backwards. And you could take your prescription to the pharmacy, and the pharmacist would give you a inert pill of either sugar-based or like talc or something. And it would actually, and you may even know it's placebo. Like your doctor may even tell you like, this is not an active drug, and you'd still take it because psychologically it affected you. There's also, if you proactively explain the drug to someone, this is going to make you feel poorly, this is going to make you feel good, it could exacerbate the thought process of, experiencing that drug. And then there's always mental health issues during transport. So here is a interesting concept that I want to kind of bring home is types of drug response. There's predictable drug response. You give a drug and you know what the outcome is going to be. It's anticipated response, but maybe not always wanted. So you could be giving morphine, and morphine causes histamine release and can cause itching. It may not be a side effect you want to get, but is it a predictable response to the drug?
What is it about narcotics that commonly cause nausea in patients?
There's several different concepts or theories, but the major one is still the histamine release. Okay. So you have histamine release, you have vasodilation, it's kind of like a vasovagal effect, and that feeling of exposure can cause nausea. In terms of predictable drug response, you really want to worry about your at-risk populations. Pregnancy, genetically susceptible patients, if they're immunocompromised or they're hemodynamically unstable. You never really know what's going to happen or what a drug's going to do in those populations. Iatrogenic drug response is an adverse effect that could cause other disease states. So you provided a medication and you caused a disease state. Famous ones are using corticosteroids chronically. They can cause peptic ulcers or secondary adrenal insufficiency when you stop them abruptly. Phenothiazines can have really pronounced and terrifying Parkinsonian-like movements to patients. And then another example would be penicillin causing interstitial nephritis or renal failure. Unpredictable drug responses are the ones that probably frustrate us the most. They're the ones that probably never happen again, maybe once in a career, opportunity, we like to say, instead of challenge. An unpredictable response is an allergic reaction. We should always anticipate allergic reactions and medications in patients that have not been exposed to before, But if they don't tell you a history of reaction, you would assume it wouldn't happen. But then the truly unpredictable ones are the idiosyncratic reactions. This is unique to that patient, and you may never see it again. An example may be you gave someone Tylenol and they developed leg swelling, or they swear that it caused them to have itching only in their left eye. Thinking about cross tolerance, if a patient is chronically on nitrate-based medications like nitroglycerin sublingual tablets, and you go to start a nitroglycerin drip on them, you may not know that they have a high tolerance to the drug. So you may not know they had a cross tolerance. Tachyphylaxis is one of my favorite pharmacy concepts. It's the idea that you expose a patient to the drug and you need exponentially more and more and more drug to provide the same response. So the two most famous ones are nitroglycerin drips and epinephrine drips.
So someone who's on an epinephrine drip over a period of 24 or 48 hours, you might just continually roll it up and up and up.
Yeah, and there's different reasons for that. Maybe they have a catecholamine depletion. It might be because they're actually getting sicker. It doesn't happen to everybody, but it does happen.
And nitroglycerin and epinephrine, these are both drugs that are very, very common on critical care transports.
So don't be surprised when it happens to you. Like if you think, oh, this drug's not working, it may not be working because they have tachyphylaxis going on. You may not be able to predict drug dependence and tolerance. The patient may not be able to tell you or is not forthright about their chronic use of medications or illicit drugs. So it would be unpredictable that when you gave a drug and it didn't work. And then sometimes drug interactions cannot be predicted. One of the things that are unpredictable is the cumulative effect of drugs.
Oh, there's diltiazem.
There you go. Cumulative effect of drugs are difficult because you could be using two totally different mechanisms or the same mechanism, and you didn't realize it was going to stack on top of each other. So there's a lot of debate out there in the world in terms of rate control of patients with atrial fibrillation. If they're on baseline beta blockers, should you use a calcium channel blocker? The literature keeps going back and forth. So for me, my decision-making process is when's the last time they had their medication? And is that medication worn off or have they been non-compliant? Then it's easier for me to make the decision to use the other mechanism of action.
So maybe this fits, maybe it doesn't, but we go on a patient who's taken their aspirin for the day and they're having a STEMI, and do we give them more aspirin, or they've already taken their aspirin, and then I remember way back when it was, well, do we give them Plavix if they've had aspirin? But they're two different mechanisms that are working there.
Right. In terms of the aspirin, my general rule is a patient isn't always able to give accurate information, even if they're trying to be truthful. An extra dose of aspirin is not going to hurt somebody in a STEMI situation. You have to have that drug on board. So it's worth the risk of maybe having a double dose to make sure it's on board. So when we talk about the effects of two drugs being done together and causing drug interactions, there's a lot of concepts that get kind of redundant, but we'll talk about them real quickly. First, there's summation. Two different drugs of different mechanisms of action. So opioid plus acetaminophen. Those two together would have a cumulative effect, maybe provide better analgesia. Next, there's the additive effect. You use two drugs of the same basic mechanism of action. So atenolol plus atenolol could be one where you double dose a patient and essentially cause an overdose. Because either they didn't tell you you're on there, they either didn't tell you they're on that medication, or you scheduled it wrong and they got a double dose within 12 hours, for example, or 6 hours. Or you could use atenolol plus metoprolol. You're putting two beta blockers on top of each other, you would have an additive effect. There's a concept called synergism. I love synergism because, talk about, in interpersonal relationships, how you have one person plus another person and they're exponentially more effective together than they are apart. It's the same idea with some drugs. You could put levodopa plus carbidopa, which are individual drugs that you would use for Parkinson's, but when you use them together, they actually affect each other's metabolism and affinity and make a more powerful drug. So it's kind of like when you put a superhero plus the radioactive spider, you put them together and they're awesome together. Potentiation is kind of a complicated thought process, but essentially when you put drug A and drug B together, they're also greater than the effect of drug A or drug B apart. Now that sounds like synergism. It's just not to the exponential effective synergism. It's just potentiation. So Bactrim, which is an antibiotic, is a combination of sulfamethoxazole plus trimethoprim. And then we start thinking about the things that don't add together. Maybe they take away from each other. We call that either antagonism, or which would partial antagonism would be with a special thought process for this, or interference, some people call it, where 2 plus 2 is actually less than 4. So Suboxone. Suboxone is a medication used to treat opioid withdrawal. So you may still get pain relief, but you're not going to have all the side effects of an opioid. So maybe you'll have less constipation. You won't have as much respiratory depression. Now, if you take that drug enough, you'll still have all those things, but when used appropriately, it's a partial antagonist. Suboxone's and methadone also methadone's a full mu agonist, whereas Suboxone's a partial. When you have patients on chronic medications for opioid withdrawal, or maybe not even opioid withdrawal, but chronic pain management, their tolerance level is much higher, and it takes a lot of medications to actually give them pain relief. Suboxone is different because it is a partial agonist antagonist. So you do have some of the mu activation, but it also has some of the mu antagonism. So when you're trying to give, let's say someone overdosed on Suboxone, but maybe they overdose on meth too, and they're super agitated, but not with you enough to follow commands. And you're like, okay, maybe if I give them some fentanyl or some pain control en route, the drug actually doesn't work because the partial antagonism of Suboxone. It makes it really complicated to treat these patients. I always feel so badly for the patients who come in with a broken leg who are on Suboxone. There's no way for me to treat their pain well until the Suboxone is metabolized. It's just a difficult process, and it makes it hard on the patients, but it makes it hard on us because we're trying to find creative ways to help their pain relief. And then finally, we have complete antagonism, which we talked about earlier, naloxone. We put 2 plus 2 together equals 0. So when people ask me what my job in the ER is, my job is to prevent from medication errors from happening. That's my first job. My second job is to be a source of knowledge to my staff. And then my third job is to optimize the right drug, the right dose, optimizing for patient-specific characteristics. So when I orient our new nurses, there's certain things we talk about. Nursing school, and probably in medic school and everywhere else, everyone talks about the 5 rights. You have the right patient, the right drug, the right dose, the right route, the right time, and the right formulation. I would like to introduce experience and art of practice experience. So, have you given this drug before? In your mind, you should be asking yourself, what happened when I did? Why is this drug even being prescribed or indicated for my patient? I can't tell you the number of times people just give the medication because it's ordered and they had no idea why they're giving it. Do you know what a normal dosage is? If the order is outside the normal dosage, you should probably think twice about it. Do you know what the side effects and expected outcomes are? And then finally, like we talked about earlier, do I know how to monitor for the outcomes of this drug? And do I have that equipment to monitor? I wanted this to be a tips on how to avoid medication errors, but it really became a list of how medication errors occur. So one of the things that I always recognize when a patient comes in from an outside facility is the variety of concentrations of infusions that come in from across the country. One of the leading pharmacy organizations is actually trying to make a standardized concentration rule for across the country, but that will be a lot of compromise and argument later. Another thing I noticed is lack of appropriate labeling. I cannot tell you how hard my facial nerves twitch when someone comes in with a 50cc saline bag with a vial taped to it. Don't do that to Aaron. You should put a full label on it: drug, dose, concentration, and at minimum the rate of administration. I also like to put on expiration date or time on it if you know it. Line compatibility is something I see with transport a lot. I'm having issues. So blood products should always be infused alone. You should never infuse drugs other than saline or lactated ringers in with blood. Non-compatibility. Compatibility information in flight is probably not possible. Let's all be honest. So at that point in time, if you have the line access, it should be one drug, one line. Another kind of going along that lines is you should never put 3 drugs in the same line. Just because drug A and drug B was studied together and drug B and drug C were studied together doesn't mean drug A, B, and C were studied in the same line. At that point in time, you're talking about increased concentrations of osmolality. You're causing maybe some acid-base issues. So 2 drugs, never 3. Inappropriate rates of infusion. This happens just because pumps could be tricky, but also because someone is doing free rate calculations and maybe calculated incorrectly. I've just heard people say, yeah, we started the alteplase for the stroke and I didn't really know the dose, so we just kind of kept going. There's high-risk drugs should always have a timeout and say, what exactly are we doing and why? Environment's kind of hard when you're in a very chaotic scene, bad lighting, lots of noise. Errors can happen that way. Lack of patient information is probably something we are all very aware of. I have no idea about this patient. They can't tell me. I have no idea that they're allergic to X drug. So, being prepared for whatever that drug's outcomes could be could help you. It's about mitigating the outcomes, the bad outcomes, when you don't have enough information.
The highest risk for any patient to have a medication error is in transport. When you think about it in the emergency department, a doctor may order the drug and then the nurse has to go to, now we have the computer systems, whatever it is, and enter it in. And the order has to have been entered into the computer. And then the nurse takes the drug, they take it into the patient's room. Then they have to scan the patient's badge. Then they have to scan, the drug, and then they have to scan their badge. And so there's so many checks and balances, but out in the field, this patient needs a pressor. All right, I'm going to calculate it in my brain, maybe write it on a paper. I'm going to drop, Levophed. I'm going to drop like 16 milligrams of Levophed, push it into 250 milliliters of normal saline, and run it in. And oh geez, I forgot to check for an allergy or whatever because there's allergy alerts in the computer in the hospital. So be aware you probably have, even without knowing it, and most likely you've done it with knowing it, and you will do it in the future, make a medication error. So remember, it is a real possibility and it will happen. So don't just blow this off like, yeah, I don't go through my 5 rights because, it's one patient, it's in the back of our, helicopter or ambulance. There's no way I'm going to make a mistake. It's just, that's not possible. You're going to make mistakes.
And when you recognize that an error has happened, there's a couple things I've watched over the years. There's the panicker who can't do the next thought process of, okay, what do I need to do to mitigate this error? So do I need to put additional monitoring on? Do I need to bring my doc in or my pharmacist in to say, let's make a plan? You should always, let your team know that an error has occurred. But so there's the panicker. Then there's the denier. I didn't make that error. I don't make errors. And then there's the angry. Well, the system didn't catch that error. It's the system's fault. So at the end of the day, during transport, as long as you know how to monitor and mitigate for a potential error, that's the best you can do. And we all recognize that.
Well, and you missed one that I think is common. I'm not going to tell anyone about that error and hope nothing bad happens.
Yeah, I try not to think about people that way, but it does happen. Misuse of protocols. This is one of my new pet peeves, actually. It's I can give up to 10 milligrams of midazolam, so I'm going to give all 10 milligrams of midazolam now, IV, all at once. And all of a sudden the patient is not breathing very well, and now I'm putting in oral airway in, and we're flying into the ambulance bay for a patient who is completely, not fine, but breathing 5 minutes before.
Ago.
So that's my new favorite, misuse of protocols. And then administration site error. Should this medication not been given intramuscularly? Should this drug not have been given in a peripheral line? Or did that line fail and now I have a vesicant where that site, that site was administered?
And one that could happen in critical care transport, you're not used to transporting patients. Even if you are in the critical care transport world, you don't transport a lot of patients with an ART line in. And you push a drug into an ART line and you may have just killed that patient, or at least, killed their arm or whatever it is.
Or made that next 45 minutes of your life really stressful. In terms of medication management, this is really important in this day and age to really consider about your storage and your security of your medications. Storage is important because you think about refrigeration needs of medications, their limited stability time, and we're in extreme temperatures. You know, us being in Utah, we can have 115 degrees, which thankfully we haven't had yet this summer, or you could have 4 degrees. Freezing and boiling drugs make them less active. There's always debate because no one really takes these drugs to extremes very often to see what happens. But I can't tell you the number of times when I've been on ride-alongs and they have their medication, like yellow box, just in the direct sunlight. And I'm like, no, please, it's dying.
You weep for your drugs because they're
my children.
It's your life. Well, you know, one thing that actually is common is, you know, when we transport people out of Rock Springs, Wyoming, in the dead of winter and the wind's blowing, it actually is common. Your lines will freeze, and all of a sudden you've got ice chunks.
The first time I saw this happen come in from AirMed, I was like, "That's real." It really does happen. Your line will freeze. And do you guys have like protocols, or like do you have hand warmers? Do you pray? Like, what do you do?
Well, yeah, so we do have warming blankets that are chemically activated, like a gigantic hand warmer.
Like a gigantic charcoal hand warmer.
Right, but the idea is not to put that around your drug. It's put that around the patient. So the lines, when you're in cold situations, you bundle them in with the patient.
Tuck them in.
Right, so that they're not exposed to the temperatures and winds.
Yeah, we need to talk about me getting on a flight. Anyhow, so let's see here. Security of drugs. There are a lot of federal and state laws in terms of keeping records and safe control of your medications. Your doctor actually is using their license to obtain controlled substances for your rig. If there's enough errors or loss of drug, they can actually lose their rights to prescribe controlled substances. So the security is important because you can make sure there's a lack of adulteration. Adulteration is any time a medication is stored, used, or labeled incorrectly. But there's also the idea that if you have secure ways of keeping your drugs, that you'll be able to keep more accurate records, and you'll be able to make sure that people who shouldn't have access to medications don't have access to them.
Okay, that does it for the fundamentals part of the series. Take a break and digest what you've just learned before moving on to the next presentation, where we will be discussing medications that affect the cardiovascular system.